may I please request the chairpersons to proceed to the stage. First, we have Dr. Vijay Raj Saxena, sir. Sir is an eminent radiologist with more than 40 years of academic experience. Sir has acted as the HOD of RML Combined Hospital and has various publications to his credit. Welcome, sir. Next, we have Dr. Sri Prakash Vatt, sir. Sir is a senior radiology consultant at Charak Diagnostics, Lucknow. He has acted as the chief medical superintendent at Sachawale Hospital and as a senior consultant at SPM Hospital as well as at Balrampur Hospital. Welcome, sir.
I invite Dr. Durgesh Kumar Dwivedi, affiliation professor, junior resident, Department of Radio Diagnosis, King George Medical University, KGMU, Lucknow. Education, PhD in NMR and MRI from AIMS, New Delhi. Postdoctoral fellowship in advanced MRI methods. Radiology duty Southwestern Medical Center, Dallas, Texas, USA, and radiology at University of Chicago, IL, USA. Please come.
Thank you so much for the introduction, sir. So this is the paper we published just last week. So this is about, because Dr. Gaurav Bose has presented very nicely on the prostate MRI. So this paper just discussed all the advanced, we call it MRI based virtual pathology of the prostate. So if anyone has interest in advanced pulse sequences, so we have covered everything like verdict MRI, hybrid MRI, CEST MRI, all the T2 relaxometry, all those things have been covered in this paper, and this is just published last week. All right. So coming to today's second topic, that advanced MR pulse sequences. This is a little wide topic, but I'll try to cover as much as possible. So outline of my talk is as follows. Just briefly cover the history of MRI, all the various magnetic fields, parallel imaging, parallel transmission sequences. Now you can see here, we have tons of MRI pulse sequences. Now, not only these sequences are very important, but each of these sequences have many variants. Like suppose if we have echoplanar imaging, we have single shot echoplanar imaging, then we have multi-shot echoplanar imaging. So all of these sequences has so many variation. Now if you go further, you'll see more and more sequences. So basically, it's a very big topic, and I will try to cover as much as possible. Now this is my favorite slide, because this is the single area in radiology, not whole radiology. Just in MRI, you can see the number of Nobel laureates. So it started off with the 1944 II Rabi. Rabi was given Nobel Prize in physics for his discovery of magnetic moment, which is the basic behind MRI. Then Bloch and Purcell were jointly given Nobel Prize in 1952 because of the Bloch magnetization. I will briefly cover his magnetization. Without his equation, you can never derive T1 and T2 relaxation. Then Ernst and Wuthrich were the guy who developed, he died like I think 2-3 months back, 2D NMR, and using his principle, Peter Mansfield, who was a physicist, and Paul Lauterbur, who's a chemist, both jointly were given Nobel Prize in 2003 for developing MRI. Now another guy, Raymond V. Demadian, is also, we should discuss about him, because he was the guy who developed the whole body scanner. So in this table, I just want to highlight any spin that has non-zero spin, non-zero total spin can be used for MRI. So carbon 12 cannot be used for MRI. It is used in PET imaging. O16 cannot be used in MRI. It can be used in PET imaging. But all other isotopes, so normally 90% times we use proton MRI. Nowadays Yale University has started doing deuterium imaging, deuterium D2O imaging. So H2 can also be used. C13 you can use. It's called hyperpolarized nowadays. C13 spectroscopy were very popular, and hyperpolarized is very expensive machine. It's like only 10 or 15 installation whole worldwide. Then you can do nitrogen, you can do oxygen, you can do fluorine, you can do sodium, and we did some little work on phosphorus spectroscopy for energy metabolism. So you can see it's a very rich area. It's a very wide area, although these things are very, and the reason I am showing here because you see the gyromagnetic ratio and relative sensitivity. So you can see proton has the best values for the MRI. Other nuclei, why they are not as much popular as proton? Because our body is made of H2O 80%, and other nuclei is very less amount available. So we need a lot of time, you know, so patient needs to lie down a longer acquisition time, and these are less sensitive techniques also. Now this is one magnet and many contrast, so we can assess anatomy, we can assess microstructure, we can assess function using bold, perfusion, motion flow. We can assess metabolism using spectroscopy, chemical exchange, saturation transfer, non-proton MRS, that is phosphorus spectroscopy. Now if you go from left to right, sensitivity to early changes are can be picked by using these methods. So these are very popular method to pick up the early disease. But the problem is low SNR. So if you go from right to left, then of course like anatomical structure are better visualized at T1 and T2. So SNR is very high at this end. However, sensitivity to early pickup diseases are higher at this stage. And you can see we have various contrasts available. Now coming to the basic physics behind MRI, we need to have a proton in water. We need to have a one polarizer. Polarizer is magnetic field B0. That varies from 0.55 Tesla, 1.5, 3 Tesla, 5 Tesla, 7 Tesla, and so on. We need to have B1 field, like last time we discussed, exciter, that is RF field. And then we have to have a gradient system. Now gradient is very important whenever you join any faculty position or any, like whenever you are in a purchase committee. This is often a very controversial term. What should be our gradient of the system, and that depends and that decides your cost of the imaging also. So normally we have 45 millitesla. Slew rate is can go up to 200 Tesla per meter per second. Nowadays we have 280 80 millitesla per meter also. We have gradients, and now we have 200 also. So Siemens has 200, and the gradient purpose is to do spatial encoding. Then we can have coil receiver. Then of course we need computer to reconstruct and image the data. Now this is just to walk you through what is happening inside inside this. What is happening with the MRI. So you see here water, our body is made of water. It has 2 proton and 1 oxygen. If you just focus on 1 proton nuclei, you can see proton. What proton does have? It has a charge associated with it, and it has inherent spin in it. So the charge, if you combine charge and spin, they give you the magnetic moment. Now magnet moment, so the proton behaves like a tiny bar magnet, you know. Now the moment you place that bar magnet into B0, that tries to align themselves according to the B0. Now other than charge spin, it has also mass. Proton has a mass. Now then it behaves like a spinning top. Now spinning top we know lattu jo hai, agar if it is under gravity, it starts wobbling, it starts precessing around it because of gravity or gravitational force. So our spin is also, whenever we put place into the main magnetic field, because of these 3 combination, it is started precessing around the main magnetic field, and that is at the Larmor frequency. So omega equal to gamma B naught is the master equation in MRI. I'm not going to that further detail, but just to give you a basic idea what is happening inside the MRI. And this gives the resonance phenomena. Now what is inside the MRI? Now it's a very complicated system. I'll just focus on three things. Main coil, that's B0. It is inside the cryostat. Then we have three kind of gradients for spatial localization, X, Y, and Z gradient. And then the body coil or transmit receive coil, that's called RF coil. So again you can see a traditional MRI scanner. Then we have coil placement. Now on top we have magnet, gradient coil, RF coil, patient table, and then the complicated electronic circuitry. So if you see here, we'll just focus on three things: main magnet, body coil, and as well as gradient. Now this is just to give you what is the Cartesian sampling. Now if you just focus on this, so I'll not go into the detail of this. We are just sweeping through one K-space line. So you can see here we are getting into negative direction because of the phase encoding gradient. The moment we have the reverse polarity gradient, one K-space being acquired. Now we change the phase encoding gradient, second K-space is acquired. We keep changing all those phase encoding gradients, and then all the K-space are filled in MRI. Why K-space is important? Because the Fourier transformation of K-space is what we get in our MRI scanner. So here we have, we put the patient's scanner, MR imager, we get the K-space, you do the Fourier transformation, and you get the images. Now here you can just see, so we are just walking through our K-space, it's negative, you keep looking at this image, we hit the center of K-space, and we get the full picture. This is what happening with the Fourier transformation. It has real component as well as imaginary component. We are focusing on just magnitude component. Most of the time we take the magnitude susceptibility weighted images where we take the phase component. Now how does signal depend on TR, T1 and flip angle? This is a very famous equation where you can see here how the transverse magnetization is related to the longitudinal magnetization. E raised to power minus TR over T1, sin alpha 1 minus cos alpha over E raised to power minus TR over T1. And this is Ernst angle. This is the angle where you get the maximum amplitude. Of course, 90 degree for spin echo. Now, why the Bloch and Purcell were given Nobel Prize? Because this is the equation. Without this equation, you cannot get any value of transverse or longitudinal magnetization. So what we do in MRI, we solve this equation. It's a very complicated equation. We have putting in the rotating frame. Because in rotating frame, solving this equation becomes very easy. If you are using lap frame, we cannot solve the equations, very complicated. So T1 changes are slow in the order of 100 millisecond. T2 changes are in the order of tens of millisecond. If we are doing the diffusion, we add one more term for the diffusion weighted images. So this is the equation for which Bloch and Purcell were given Nobel Prize. So what is the T1 contrast? If you see just two kind of different tissue, we are flipping into the 90 degree, and the recovery of that magnetization is the T1 contrast. This is the signal equation. Rho is the spin density, and TR and T are governing T1 and T2. This is the typical T1 and T2 values in various tissue. Now you can see here, wow, spin echo and GRE sequences can be used for the T1 and T2. So this is a common practical like Viva question for the residents also we ask, like, can we get the T2 weighted images using GRE also? So you can here see, if we are having T1 weighted, short TR, short TV, T2 weighted, long TR, long T, here you can see, and for proton density, we have medium and short medium T. But if we are having gradient based echo imaging, then we add another term, because here we have 180 degree pulse, here we have flip angle of 30 degree to 50 degree, and here we have changed the flip angle again. Now here we don't get true T2, but we get the T2 star because of the magnetic field imperfection or inhomogeneity. Alright, so what is T1 and T2 relaxation? So longitudinal, it's also called T1 relaxation, spin lattice relaxation. So it's typically in the order of 10 to 100 millisecond. It increases with the increasing B0, and it decreases with the contrast agent. In summary, short T1s are bright on T1 weighted images. Transverse relaxation or T2 relaxation, this is a very basic behind, which is often not covered in our classes, but it's very important to know what is T1 and T2 before going to the advanced pulse sequences. Liquids have long T2s, solids have short T2s, and long T2s are bright on T2 weighted images. Now this is the typical values at 1.5 Tesla. Now this is a very famous curve which often our residents get very confusing. What is happening here? Why T1 is behaving like that? T1 behavior is not straightforward in the magnetic field, because you can see here T1 behaves like a bell curve here. So you can see here, because that's why we call it spin lattice. So this is very important, because it is not only changing with the TR and T, but it also changes with the surrounding of the molecule. So if it depends upon the molecular motion, it depends upon the molecular size, it depends upon the molecular interaction. Why I am saying here, take the example here, we have water, but three condition of water. Once we have here ice, here we have bound water, here free water. But all the water component have the different T1. So you can see here, ice has a different T1 values than the bound water. And then the free water will have again maximum T1 values. But T2 behaves like kind of exponential value. So T1 and T2 behaves differently whenever they are in a different molecular interaction. So again, just wanted to emphasize here, T2 is always shorter than T1, but it depends, the T1 depends on the molecular motion, molecular size, as well as molecular interactions. T1 can be measured using inversion recovery. T2 we know is the 37% decrease of transverse magnetization, and the recovery of main magnetization to the 63% is called a T1 relaxation. Spin echo sequence, we have 90 degree and 180 degree. We can generate T1 weighted, T2 weighted, and PD sequences. This is a typical spin echo sequence. We have 90 degree pulse, 180 degree pulse. At TE, we get the echo, which we have seen in the gradient cartoon. And this is a typical spin echo pattern we get by changing the TR and T. Gradient echo, here we change the flip angles and TR to get the T1 weighted, T controls T2 star. And this is again the same picture. Why it is ringing? So we do have 5 minutes. So then this is a typical signal equation. Now gadolinium based contrast agent is injected intravenously, and we can have like a contrast for pre-contrast and post-contrast. Basically it shortens T1. Then we can have a contrast enhanced MR angiography that's acquired by 3D T1 spoiled GRE sequences. Then we can have perfusion imaging. Perfusion can be of two types. T1 weighted, whenever we call it, this is called dynamic contrast enhanced MRI. And T2 star weighted, that's called dynamic susceptibility contrast enhanced. So you can see here, this is a typical DCE MR. We can generate a lot of kinetic parameters, perfusion maps, like this is transfer coefficient map, K-trans. Then you can have CBV map and other thing using the dynamic susceptibility contrast. So DSC is a T2 star, DCE is T1 weighted. So perfusion can be of three types. One is standard T1, then MRA, and then we have DCE and DSC MRA. Now coming to the inversion recovery, so you can have a short T1 based inversion recovery of three types. One is a stir, where we have short T, inversion time short TI here, like if you want to null the fat, and here you can null the fat here. If you have flare, then you can have longer inversion time, you can null those component. And then we have also MP range based sequences where we have medium inversion time. Water and fat can be suppressed or enhanced using MRI. So these are called like in phase and opposed phase images. Chess is very famous sequence that is clubbed with the press sequence in MR spectroscopy. Then Dixon based is nowadays very popular sequence for the fat imaging. We can have 3-point Dixon, 5-point Dixon. These means we are acquiring 3 echo, 5 echo, and complicated. 2-point Dixon is very simple. You are just acquiring fat and water images. Now, if you are adding one more equation, one more term to the block equation, that becomes a diffusion. If you solve that, then you get the diffusion and ADC terms. Now, this is a very famous, very basic pulse sequence, statistical Tanner sequence, where we acquire 90 degrees. This is spin echo based sequence, and 180 degree followed by bipolar gradients, and then you get the echo. So disadvantage is diffusion, like we saw in the previous lecture. We have a limited spatial resolution, and we often face the image distortion. But we can use parallel imaging as well as multi-shot imaging to fascinate as well as to reduce the time. Now diffusion, we know it's a random motion because of thermal collision. We can have a pure T2 effect that is proportional to magnetic field gradient square into time. Now I just wanted to emphasize here that B value does mean the amount of diffusion weighting here. So here, if we have a stationary spin, you can see the phase shift is nulling after the diffusion gradient. But if we have moving spin, then we get the phase accumulation. So this is how we are acquiring the diffusion weighted imaging. And diffusion is a very vast topic. I mean, you can, it's a lot of books have been written on this topic. Because we have DTI, DKI, IVIM, Al-Nahdi, SMT, so many variants of this. It's a very popular, very famous sequence in MR field. I'll just focus on one DTI here. So you can generate trace map, we can have like radial diffusivity, fraction anisotropy, and all those things, basically just to measure the anisotropy. Now, this we have already covered. How can we do the perfusion MRI? So basically, we need to have a good temporal resolution. We acquired the T1 map before the gadolinium contrast, and then we acquired a series of acquisitions after the intravenous injection of gadolinium-based contrast injection, and how you can acquire using the 3D SPGR pulse sequence. Now, so here again, you can use the B1 map just to correct your variation in the field. Then you can acquire the baseline T1 map, and then what we used to do in kidney and other places, what we do, we acquire the dynamic signals at various time point. Normally 5 millisecond is temporal resolution in kidney imaging. And then you can have arterial input function information available, and then you can fit into the Tufts model and other thing to calculate it. How do we process the DCE MRI? There are 3 kinds. Normally, what we do clinically here, qualitative, but now people are doing a semi-quantitative analysis, that is area under the curve, time to peak, or slope. Then we have done a lot of work on quantitative MRI, DC MRI, where we use modified Tufts model, extended Tufts model, 2-compartment model. This will give you K-trans VEVP map. MR spectroscopy, it's very close to us, and we have done a lot of work on this area. So basically, MR spectroscopy can be done 2 types. In the interest of time, I'm not going to go into the detail of MR spectroscopy. Again, it's a very wide topic. But briefly, it is we can do the single voxel spectroscopy. So what you need to do here, you need to water suppress, because water is very high in molar condition, and what we are detecting, choline, citrate, RNA, whatever the metabolites we are interested in, these are in the millimolar range. So we need to, without suppressing water, you cannot detect, or you cannot see any other metabolites. So you need a robust suppression, and that's why you need a shimming also. Without shimming, you cannot suppress it properly. And the localization of this voxel, this can be single voxel, multi-voxel, can be done the press, steam, laser, semi-laser, and so many other methods of people have developing that can be done for the localization, and then you can do the, you can acquire the echo. Coming back again here, so you can see here, this is based on the TE values, you get the different spectral pattern based on the, because of the T2 differences of the metabolites. So this is a typical spectrum, a brain spectroscopy you can see here. So we have all kind of metabolites. So it's a wealth of information you can get here in the brain or any organ other. So you can have like energy metabolism here, that is like over here somewhere. Then you can have neurotransmitter, glutamine, GABA, and other metabolites here in this area. Then you have membrane metabolism in this area, and then you can have also antioxidants and other information available. Coming to the function MRI briefly, fMRI, nowadays people have started doing only resting state. Earlier it was only active state. It was rather a little complicated because you need to have paradigm generator and all. Without paradigm you cannot acquire those sequences. Then the post processing also very cumbersome. But what we do here is basically it works on the blood oxygenated level dependent, and basically it works on the principle of oxygenated and deoxygenated hemoglobin. So oxygenated, when the neuron gets activated, you need more oxygen, and blood pumps in, and then we get the enhanced into the bold signal. So and image contrast can be acquired using T2 weighted GRE based sequences, and these are the typical. So you can have all the mapping of the brain, and this is a typical hemodynamic response curve of the bold signal. Coming to the, I'm just going to, I think just in 2-3 minutes, I will finish that. Then we have susceptibility weighted images. This is basically T2 star based sequences, again shortening of deoxyhemoglobin in veins. And here you use the phase map also. So again, susceptibility mapping, it's again very important in Alzheimer's also. We try to do the QSM and on quantitative susceptibility mapping. We'll see how it goes, but it's a little bit complicated. It's not straightforward. It's not available on scanner also, the post-processing of these sequences, but you can just get the magnitude and phase images. Then you have non-contrast MR angiography. That's we can have two types. One is TOF and another is phase contrast MRA. Repeated MR pulse sequences pulses are used to saturate tissue. In the first one, TOF MRI.
Dr. Durgesh, time is over now. Please.
Oh, just I'm going to finish.
Conclude.
Okay. Then the MR fingerprinting. Again, fingerprinting just to give you basic idea, like it is at the same sequence you can get the T1, T2 proton density, and how it does using the dictionary matching. Motion reduction can be done using propeller sequences. And zoom is very popular for diffusion because you can have shorter, small FOV without having artifacts. So on our machine we have. Then compress sensing, you can accelerate the images. We are trying to get the multi-band sense also. It's very fast. Once you have sequence of 50 minutes, you can reduce it to 5 to 10 minutes, but it's very expensive. Then another sequence is very popular, that's called CEST MRI. It's called chemical exchange saturation transfer, where you saturating the metabolites and transfer those saturation like empty transfer to the water, and you see the signal component. Thank you so much.
Thanks, Dr. Durgesh, for nice lecture over the simple sequences to more complex sequences. And in such a short time, it's very difficult to compress this MRI in a talk of 20 minutes. So I think Dr. Gaurav, next time he has to be given more time for this.
Yes,
no,
it's
physics is too difficult. We cannot give him more than 20 minutes.
So many,
I'll give you 15
complex
minutes next time.
physics equations. Really, it's great.
Thanks,
Dr. Durgesh. Thanks, Dr. Durgesh.
Okay,
Any
Durgesh,
question,
I have some few questions.
Yes, sir.
But promise me, you are a scientist. I know you will not talk of equations. You will not talk of graphs. The last time I studied those was 17 years ago when I was a resident. Just give me clinical answers. Okay. You talked about 5 Dixon method. Now, I know the 4 Dixon method in which I have water only, fat outphase, in-phase. What is this 5 Dixon technique?
So basically, if you go to the liver imaging, if I give the example for liver, so people have started doing some various kind of fat fraction and other thing. So those are especially devised for the liver and other organs.
So that is for quantification of fat,
yes,
you mean to say?
Yes.
Okay.
Yes.
Second question, black blood imaging. There is a lot of talk about black blood imaging. What is the clinical utility of it, and what type of sequence is black blood imaging?
This is not my area. So
okay, done. Yeah. Next question. So when I was a resident in SGPGI, Dr. Gupta was there, and there was a lot of, they used to do empty sequences, even they do it today. And it was said that empty sequence is used to differentiate tuberculosis and NCC. Today, does empty sequence have any importance? Is it clinically relevant?
It is. People have, so MT has a lot of variants. Now people have started this called IHMT. It's under development. It's called inhomogeneous magnetic transfer. So basically multiple sclerosis guy and all, people have started working a lot on MT sequences.
Right. Okay. Thank you.
Thank you.
Durgesh.
Thanks, Dr. Durgesh.
I want residents, because this is the thing, all the examiners, come and ask.
Yeah. You like it or not, you will have to study MRI physics for MD examination.
Thank you.
I think this is the worst part for a radiologist, the physics, and especially MR physics. Why is it so tough? Why do you scientists make it so tough? So many arrows, so many graphs, so many equations. You were telling this equation, because of this we get this. How to remember those equations? How do you remember them?
So we need to work on those things little bit,
Wow.
Because without block equation, it's very complicated also. So people have once it comes to the clinical setup, it becomes so easy. You just put the ROI, but we need to know what is going behind the scene also.
Yeah.
So it's those things cannot be avoided also.
Wow. Thank you so much.
Thank you.
Next speaker, Dr. Vaishali. Please, Dr. Vaishali, welcome to the dais. Dr. Vaishali Upadhyay, Senior Consultant, Vivekanand, Lucknow. She did MD Radio Diagnosis from IMS BHU, MNA MS Fellow of Indian College of Radiology and Imaging, RSNA Fellow Musculoskeletal Imaging, Case Western Reserve University, Cleveland, Ohio. She is Editor, Journal of Comprehensive Clinical Practice, Area of Interest, Peripheral Nerve and Plexus Imaging. She had 45 publications and 8 books chapter. Really, she is wonderful. Please clap for her. She's now.
No, I think I should clap for the audience. इतने लोग बैठे हैं. I'm very surprised and I'm very happy कि कोई सुनने वाले बचे हैं.
Her topic.
मतलब वाकई मैम कमाल हो गया मतलब है.
Her topic is on brachial plexus. This is one of the complex MRI. So I think everyone should have listen very peacefully. Thanks.
Okay.
Please, Dr. Vaishali, please.
Thank you, sir, for the introduction. And it's a complex topic for which I can speak up to an hour also. But because of shortage of time, I've condensed it to 20 minutes. I'm sure it's not the best possible condensation, but if you have any doubts, I'm here to answer your questions. So this is going to be the outline of my talk because I think it's difficult to understand without revising the anatomy. To make it easy for you, I'll just explain the basic anatomy and sequences first, and after that we can go to a couple of cases. I think that would be fair enough. So if you just see a diagram of the plexus like this, all zigzag lines, it's going to be very confusing. So let me revise it and make it simple. The brachial plexus is formed by ventral rami of C5, C6, 7, 8 and T1 spinal nerves. Then C5 and C6 join, they will form upper trunk. C7 continues middle trunk, C8 and T1 join lower trunk. And then all of them divide. Sabki do divisions hai, anterior and posterior. So I have marked all the posterior ones in red. So sare posterior divisions, posterior cord. Then divisions from upper and middle trunk. The anterior divisions are left now, so they will form the lateral cord, and anterior division of the lower one will form the medial cord. And then after these three cords, we'll have the terminal branches. From the posterior cord, you have radial and axillary. From lateral, you have musculocutaneous and lateral root of median nerve. And from the medial cord, you have ulnar nerve and medial root of median nerve. So I hope that's clear. Now when you imagine all the plexus coming from the cord towards the axilla, it's traversing through all the spaces of the thoracic outlet, okay? So there are different landmarks which will help you decide ki lesion kahan pe hai. And so those landmarks can be the scalene triangle, that can be the costoclavicular space as well as the pectoralis minor muscle. So these are all different landmarks through which the plexus passes and helps us to localize the site of the lesion. This was all about the postganglionic plexus, but the origin itself is from the spinal cord, so we need to know about the preganglionic plexus also. So this is the spinal cord. You have ventral rootlets forming the ventral root, dorsal rootlets forming the dorsal root with the dorsal root ganglion. So roughly, because this is at the level of neural foramen, so the plexus जो इससे पहले वाला है, that is contributing to the preganglionic plexus, and जो इसके बाद वाला है, that is postganglionic plexus. Now let me tell you why it's so very important to know this. Because if roots are avulsed from the cord, so that kind of surgery is not yet possible, that you're joining back the roots to the cord. But postganglionic plexus is amenable to repair. So if injury is postganglionic, then something can be done surgically, but if it's preganglionic, then it's a bad prognosis for the patient. So I'm not going to detail about all these branches. Next thing which is important is this. So what's going to be the timing of the scan? If somebody is just having infection or some tumor, you can schedule as per the convenience of your unit. But suppose there is trauma, then you don't want to image too soon. I'm sure you've heard in many other lectures, like even in the prostate or anywhere else, that hemorrhage is there and that will obscure your findings. Same thing applies to the plexus as well. So if you have too much of edema and hemorrhage, then you don't want to image the plexus too early. So ideally you should give 3 to 4 weeks for imaging of the brachial plexus. And what about 1.5T versus 3T? Definitely 3T is going to give you better quality images, faster imaging, better signal to noise ratio, and better fat suppression. So 3T is the way to go. But having said that, even at 1.5 Tesla with proper protocols and a good technical person in place, you can get very good results. And patient is supine with arms by the side. We are using both body coil as well as the cervical coil, and scan area to get a complete coverage of plexus. I prefer it to be from C3 to D3. Let's skip all this. Okay. Now, the basic set of sequences which we use to image the plexus is called as MR neurography. Now, what exactly is neurography? It's not just one sequence. Remember, it's a combination of sequences. So, you need some two-dimensional sequences, you need some three-dimensional sequences. So, for two-dimensional, your workhorse are these. That is T1 weighted imaging and T2 with fat suppression. Okay. So, you cannot say ki we are doing only 3D sequences and we are getting best results. No. You have to go start from the very, basic thing, and that is T1 and T2 with fat suppression. And then you go to all these 3D sequences, and those sequences can be anatomic or functional. So you can have non-nerve selective, you can have nerve selective, and you can have functional sequences like we've heard in previous lectures from Dr. Durgesh also, diffusion tensor imaging. So diffusion tensor imaging is right now not in my own protocol and also not in many other places where where you have many patients planned up, because obviously because of scarcity of time. And even without DTI, our plexus protocol takes us around 30 to 40 minutes. And if patient is uncooperative, then you've had it. So usually we like to, plan these patients early in the morning when the routine bheed has not yet come, or when we finished up for the day, so we can give them adequate time. Now, before I go to my cases, let me just show you how to evaluate the anatomy of the plexus. So, you have to use all planes to see the plexus. You cannot skip any single plane. Remember, basic sequences you cannot skip, and any plane you should not be skipping, because each plane is giving you some sort of information. Like suppose you start with the sagittal plane, then you can see the cord. So what will you see in the cord? You will see if there is any evidence of cord edema, if there is any hemorrhage, or if it's a chronic plexus injury, you will see if there is any evidence of myelomalacia. Then you can see the intraspinal part or the preganglionic plexus. So you can see nicely these roots. These are what will compromise your preganglionic plexus. If you don't see these roots, that means there is injury at that level. And then again, if you want to continue in the axial plane, so this is the level of the scalene triangle, anterior and middle scalene muscles, and the plexus is passing through this level. Then you can use the sagittal plane. So again, in sagittal plane, you can use the same landmarks but see it in a different manner. So like for example, the sagittal view will give you, what will it show you? Anterior scalene, middle scalene, and it will show you the trunks, upper, middle and lower trunks, the cross section of the plexus. And similarly, you go a little more laterally and you can see all of them have divided. So you see all these divisions. Then you can see the relationship with the subclavian vessels, the artery and the vein. So remember, each sequence is giving you some different information, and all of this information has to be summed up. Now this is a diffusion weighted image, and see this as well, this is a coronal 3D stir sequence, and both of them, if the patient is not too broad shouldered, you can see both the sides of the plexus for comparison, and it helps. And God has given you two sides and as a radiologist, the opposite side is your best friend. You can compare one side to the other side, and you can, see for yourself how beautiful it is to appreciate a lesion if you're able to appreciate the normal on the opposite side. So we have, and these are example of some very nice tractography images, which maybe in the near future, as we make progress, they may, we may start using them as part of our routine protocol as well. Now, indications of MR neurography in brachial plexus are many. So one thing is trauma, where you can, decide injury is preganglionic, postganglionic, what's the type of injury, the nature of injury. But there are many inflammatory, infective, hereditary neuropathies, polyneuropathies, tumors and entrapment. All of them can be imaged beautifully. Now let's quickly do some cases. So trauma is the most common indication. Usually, we have all these young guys driving powerful motorbikes, and they are very proud of their speeds and all unless they come with a plexus injury. And remember, it's a bad injury to have, because once they have panplexopathy, that whole limb is like, an iron load on their hand. It's not functional. They cannot do anything, and life is miserable. It doesn't have physical but emotional and, psychological implications also. And I've seen patients who are very, very depressed because nothing is working for them. Besides, trauma can also be because of these kind of traction injuries, and we even get patients who have been assaulted. Quite often in village fights, they are assaulted by a sharp-edged weapon. Okay, so one case, let's say that we start with the cord. So cord looks normal. I hope you all agree. Then this is the right C7 level, and you will find that there's a small collection which is going from the canal towards the right neural foramen. On the opposite side, you're seeing these roots, but this side you're not. So this is what you call as a pseudo-meningocele. And these pseudo-meningocele, once it's associated with non-visualization of the nerve roots, then it is an indicator of a root avulsion, which becomes a preganglionic injury. Now focus on the distal plexus. And once you see this, in C5 and C6, what do you see? If you just compare with the opposite side, they are bright. And once they are bright, they're not just bright, they have these interspersed low intense foci within them. So these are all sequelae of the trauma which has happened to the patient. When we go to further laterally, in the infraclavicular plexus, you can see again that the lateral cord is also showing some bright signal. Again, making use of other sequences and axial, we find some hyperintensity in the paraspinal muscles and also in the rotator cuff muscles, as well as a joint effusion. So the plexus, you see, once you see the plexus, don't just focus on the nerves, you also have to see what's happening around the plexus. So suppose किसी को bony injury साथ में plexus के, that is also an indication that severity of injury is high. So whenever injury severity is high, that indicates a bad prognosis finally for the patient. And with this diffusion image, you will find that you can see C5, C6 looks thickened, C7 you're not seeing. And why don't you see? Because C7 root is avulsed. So changes of degeneration have set in, and then you're not seeing C7. Then again C8, it appears thickened, and then you can see T1. And you can also compare both sides, right? So to sum this up, patient has normal cord, but patient had some root avulsion at one level, and then in the postganglionic plexus, patient was having scarring, right? So this is a combination of both pre and postganglionic injury. Now compare this with the next case. What's happening here? What's the glaring finding? There's a clavicular fracture, okay? So with the clavicular fracture, the all this plexus in the neck, you can see, is all bright and it's looking all clumped. So this is all evidence of scarring in the, you can say, in the plexus in the neck. So that is involving the trunks, divisions and the cords. And if I tell you that there was no root avulsion, that means now this becomes a case of a post-ganglionic injury. Now if you compare, in our first case we had both pre and post, and here you have only post. So if the surgeon decides to operate, this case is going to be much easier and you'll have much better results compared to our first case. So that's how you can, prognosticate these patients even before they've gone to surgery, and your reporting can offer a roadmap to the surgeon about how to plan his surgery and prognosticate even before the surgery about the results. So that patients are not after their life later on कि आपने तो ये कहा था and this has happened now, which is very common nowadays. Okay, so next let's come to the other multiple indications. As I told you, there are many things, but I just have a few cases in the time which is left. Okay. So now this is a 28-year-old male patient, and he came to us with, what did he come to us with? He said that he had some sort of viral infection, following which 2 weeks after the infection he had severe pain in the neck and then limited shoulder abduction. So when we did the MR for the plexus, if you focus on this, C5 and C6 are bright and C6 is also thickened. So this was the only positive finding in the entire study. So these findings are suggestive of the diagnosis of Parsonage-Turner syndrome. So it's, remember that it's very, very important to see not just your imaging findings, but also to take the history from the patient yourself. Do not rely on what notes have been sent to you by someone else. Always take your own history, because these findings are very common. Trauma bhi hoga, then also you may get C5, C6 like this, and neuritis bhi, then also you can get it like this. So remember that in the brachial plexus, what's most important is that you take the history yourself, right? Or you train your residents obviously to take the history themselves. So, as I said, Parsonage-Turner has severe pain in the neck, usually followed by weakness of shoulder abduction, and most commonly supraspinatus and infraspinatus are involved, but we do get changes in deltoid, teres minor and subscapularis as well. Okay, next case. So this is a lady who had been irradiated, initially she had surgery followed by irradiation for a CA breast. And you can see changes in the chest wall muscles, and along with that you see these changes in the infraclavicular plexus. So putting all these two together along with her history, now this is a case of radiation plexopathy. The important thing to remember here is that you sometimes need to differentiate from a mass lesion. So in a mass, what you will get? You will get a heterogeneously enhancing mass lesion. But here you will get changes in the plexus signal intensity, and they may be clumped, there may be loss of adjacent fat planes. So the MRN is also helping you decide what complication has occurred post radiation. Now this is another case, and this case was given to me by the late Dr. Rammohan Vadapalli sir. He had this patient with sarcoidosis who after multiple years developed a peripheral neuropathy. And after everything was done, they came to know that indeed these findings in the brachial as well as lumbar plexus were also due to sarcoidosis. Now it's not a common thing to see, and it was also the first time I had seen images for such a case. But remember that these things do occur. So if you have such a patient who develops neuropathy after a long-standing systemic illness, you can maybe you can keep it at the back of your mind that okay, it could be due to neural involvement. What about this? I think this is easier for all. This is an easy one. Any guesses, residents? Bilateral symmetrical, and I can tell you it's an adult patient who has a weakness in the upper limbs. Yes? Yes, somebody said CIDP, so whoever said it is right. So remember that it's not always that you may get bilateral symmetry, because at some stage in the illness, it may be that findings are not bilaterally symmetrical, but usually once the full-blown manifestations have occurred, things are bilaterally symmetrical. Now compare this with this case. This is a child. What could this be if it's a child? So this is some form of hereditary neuropathy. And this particular one is a case of Charcot-Marie tooth disease. So again, as I'm just wanting to emphasize again that findings overlap in a lot of conditions, in a lot of polyneuropathies, and history is extremely important. History and whatever clinical findings that you have, you must take specific note of them before making your final diagnosis. Now coming to a few neoplasms. Any guesses? So this is the this is the arm, and this is the medialmost nerve. So what could this be? Yes? So it's a nerve sheath tumor involving the ulnar nerve. Okay, so this was a schwannoma, and this was a young girl who got operated and for an ulnar nerve schwannoma. Now another patient, this guy was around 28 years of age, and he came with a progressive swelling in the neck, and initially he was not concerned because it was a painless soft swelling, but gradually he started developing some weakness in the left upper limb, so he came to us. And this is, you can see it's clearly getting saturated on the fat saturated images, so it was a lipoma, but the location was such that he was beginning to have problems for it. Another case, this I'm sure many of you get lots of cases similar to this one. What's happening here? Where is this lesion? Yes? So this is a case of a Pancoast tumor, and that was infiltrating the inferior part of the plexus, even the osseous structures, and that was resulting in the symptoms of plexopathy. So last case, and what's happening here? Yes, so you have bilateral cervical ribs, and one of them is causing extrinsic compression over the plexus. So these are forms of entrapment neuropathy. So many other reasons for them. You can get elongated transverse processes. You can get a mass lesion like an osteochondroma. Sometimes post-fracture callus formation can compress. Sometimes there are fibrotic bands, and sometimes you just don't see anything, and you only see the sequelae of the compression, right? So to conclude, I'd like to remind you of these few things. Remember the anatomy. For any radiologist, anatomy is your best friend. If you know the anatomy, you're familiar with it, your reporting will always be good. And standardize your protocol. Image a patient with plexopathy. Don't image if he has had trauma. Don't image before 3 to 4 weeks. Talk to the patient, and also keep your channels of communication open with the referring person. And before I end, I'd like to give special thanks to late Dr. Ram Mohan Vadapalli sir, without whom this presentation would not have been possible. And I guess I'm fortunate that I had the pleasure to work with him in a few of my brachial plexus papers. Thank you all so much.
Thanks, Dr. Vaishali, for timely finishing the lecture. I'm very thankful to Dr. Vaishali. She is very particular about time. I know since many years.
Bang on time, ma'am. Excellent.
Thank you. Thank you, sir. Any questions?
Quick question. So, ma'am, what is the common pitfall you come across in day-to-day practice? Is any hyperintensity in brachial plexus always pathological?
Sorry, is any
or is it the early measurement of trauma, which is one of the most common pitfalls you encounter in day-to-day?
Yeah, the main problem that that I get to see is that I get a lot of review brachial plexus MRs which come to me from outside, and the pathetic part is that they have been done sometimes on the day of the trauma, sometimes next day after the trauma. So there is so much of hemorrhage and edema that you can't do anything, you just can't write anything, because later on, after 3 to 4 weeks, when the edema and hemorrhage has subsided, then only you get a true picture of what has happened to the plexus that is there. So everything, it's very important that our residents are aware of this. And in fact, sometimes I've had to argue with my surgeons also. I've had to literally tell them, no, we need to wait. Right. We need to wait.
15 days,
See, at least, even if they're in a hurry, at least wait for 15 days. I prefer 3 to 4 week period, but, yes. So at least 15 days, I would say.
Yeah, very nicely. But just to add your question, definitely any hyperintensity that you are getting and comparing with the other nerves and other side, you are getting a normal side also, is pathological, definitely, because you don't have too much of thing to report in to define the pathology in brachial plexus, or for that matter any nerve. What you get is a hyperintensity, a change in contour, and that too in a very slender anatomy. You are not having a big anatomy, and always the FOV is very large. If you look at this, I said you image prostate and you try to focus on the prostate, say 3 or 4 centimeter. When you scan a brachial plexus, it starts from the midline and maybe the other side and going beyond the shoulder, because you have to see all the terminal branches also. So these large FOV, definitely we have limitations in going deep into the so-called structural part, microstructural part of the anatomy. So it is.
What do you do if the patient is very, broad-chested?
No, definitely the protocol goes to, first you scan the bilaterally, and that is the first protocol. Then you limit yourself to a large flex coil, use the large flex coil and use only one side of the imaging. Then
See,
that
actually,
is only
one side is, for us, one side is important, right? The affected side. So you need to image that completely. अब opposite वाला कितना आ रहा है वो जितना भी आ जाए उतना ठीक है, because you get to compare the signal intensity of the affected side to the opposite side.
Exactly, and you have a body coil, na? So you have one large FOV image, screening image, and then stir image, 3D stir image in a body coil, and then you go for a flex coil with high resolution image of the ipsilateral side.
See, it at least takes us somewhere between 30 to 35 minutes. And if patient is uncooperative, then we have to repeat, sequences. Then it becomes a problem. So we generally try to schedule these patients either in the morning when there's no, other patients are not there, or by the end of day when everything is wrapped up. ऐसे बीच में करने में then we do have a problem. Sometimes we have to, but usually we prefer when there's adequate time.
Can I add? This is a nice presentation, Dr. Vaishali.
Thank you.
So one query regarding the DTI. So we are doing routinely the DTI in 3 Tesla MRI. We are using 20 direction and 32 directions.
Wow.
So nowadays the additional rule of DTI is that is sometimes helpful not in the acute settings. In chronic cases, it might be helpful. Though if you do the DTI, you can able to measure that all the parameters of the DTI, fractional anisotropic mean diffusibility, that can be calculated. And it helps in the chronic cases, not in the acute settings. And these DTI parameters can be correlated with the post-surgery. Because nowadays the neurosurgeons, they are doing nerve transfer. They are doing nerve transfer.
Yes.
When patient of pseudomeningocele formation, they don't operate to the nerve. They are not able to interpose the nerve to the spinal cord. So they are doing nerve transposition with the muscles, trapezius muscle or another muscle.
Yes, nerve transfers are common, but nobody is doing, reattachment of the avulse nerve to the cord.
No,
so
that is not.
That is not feasible for surgery.
So that is the thing that nerve regeneration can be helpful in such situation.
Right. Yes,
so in chronic cases, we can apply DTI.
And for post-surgical follow-up.
Sir, DTI is routinely now being used to prognosticate the case because surgeons are taking up the case for surgery. So how much it is, they should wait. Actually, most of the mild, say, axonomatosis, neurotomosis, except for neurotomosis, neuropraxia and axonomatosis, they just wait for it. So DTI helps it whether we should go for surgical cure or just leave it and wait and watch and go for physiotherapy, and it heals gradually, and a good quality of work is restored.
Yeah, my neurosurgeons want DTI because he have to see that these parameters, and he compared these parameters post-surgical. We are doing after 1 or 2 months after the nerve transposition or nerve transfer, we are doing the repeat DTI sequence, because in our scan it takes only 4 to 6 minutes, not more than that.
That's
time.
true.
Yeah.
Quantitative. FA value, MD value, we can able to measure AD, RD, everything. Radial diffusion, axial diffusion.
One tip for the residents: if any one of you is interested in brachial plexus imaging, there are very good articles by Dr. Avnish Chabra. He's at the UT Southwestern University in Dallas, and he's also my virtual guru. I've picked up everything, a lot of things from him. And even today I stay connected to him for any problem that I have. So many articles by him, and also one beautiful article in Radiographics recently about 2 years back by Gilcrease Garcia and all. And that's a wonderful article. If any one of you is interested, these are the 2 things I would suggest you to read, and that will really help you a lot.
And
yeah,
and just to add, Dr. Vaishali,
activity.
Dr. Vaishali, if you permit, just to add, Dr. Avnish Chabra had recently launched the NS rats also. The rats we were talking about, pyrats and tyrats. So he has now proposed and also validated at some of the centers. So it can be used NS rat just to make the reporting uniform in our day-to-day reporting.
Yes, for residents also, like you read BIRADS, PIRADS and TIRADS. So Dr. Chabra has come up with ST-RADS, O-RADS and also NS-RADS. So these days I am also learning. I am learning ST-RADS from him only, thanks to him, because of his multiple cases and everything. But this is the way to go, and you are very happy to be born, I think, at a time when everything is there on the internet. You have so much access, and these big people also come to conferences in India. Like he came to IRIA Vijayawada earlier this year. So I think you should attend all these conferences. They'll really help you go a long way. Thank you all. Thank you. Thank you, Dr. Gaurav, for the opportunity to be here. Thank you.
Most welcome.
Thank you, Dr. Vaishali. Next speaker is Dr. Vaishali Upadhyay, Dr. Bhanupriya Singh, Consultant Radiologist and Assistant Professor Radiodiagnosis, Dr. Ram Manohar Lohia, Institute of Medical Sciences, Lucknow.
Manu is going to come and deliver a talk just before, because this is the last session. After this, all of you will be going. So just want, Mike Didana, I just want, a feedback, because for a teacher, for an organizer, it is very important to get the feedback from you guys, that how did you like the sessions? Maybe in future, what would you like to be added? If there's anything you guys want to say, then please do let us know. A lot of hard work has been put in by my residents, my faculty, me. So please, if you could share your, about this conference. This is the last session. After that, we will all be going home. It has been a long day. So if there's anything people want to share, please do share at this point of time. Anyone? Whoa, is there anything you want to improve on this? Any more topics you wanted? How was the everything okay? Anything? Please feel free to, till we are getting this set up. Yeah, it would be great. Just someone, just speak.
From the house only. Hello. Yeah. From the house only, I can say that this is a wonderfully organized conference. And as you say, that what are the topics that is left? I would say that the academics is something where there will always be something that will be leaving.
Yeah, we cannot cover everything. It is literally impossible.
Extensive topics in 3 days. I think it is adequate for this platform in the beginning, but definitely the feedback is needed from all of us.
We will be giving you a feedback form. One of my SRs will be making it and then floating it. Please do fill it. And once again, thank you for being such a nice audience, such an attentive audience. We don't get these kinds of audience nowadays in conferences who would sit till 6 o'clock and listen to the lectures. So thank you, everyone. Thank you so much. Come, Bhanu, please. Sorry.
Yes, please, Dr. Bhanupriya Singh.
Good evening, everybody, and let's begin with our lecture. Before that, I'd like to thank Sir and my parent institute for giving me this opportunity to speak, where I have been trained as a SR for most of the cross-sectional imaging. So to save time, I'd just be going through the cases, and you can do a mental self-analysis, and I will be showing images and then a short discussion about the case. So let's start. So this is a 40-year-old male who presented with trauma. So this is a coronal T1 and PD fat-sat image. So what are we seeing? So we are seeing a T1 hypointensity, that's just subchondral and reaching up to the articular surface. On the PD fat-sat image, we are seeing central hyperintensity with a peripheral hypointensity. This is nothing but AVN of the humeral head. So most of the topics will be just a quick repetition of what you have already seen. These are very common spotters. And on this PD fat-sat was the much talked about T2 double line sign, and with surrounding marrow edema. Now the second case, here we are seeing a zoomed in image of medial meniscus, right? So this was a 25-year-old male who was presenting with chronic pain in the knee on medial side. So this is just to help you along the posterior aspect of the medial meniscus. So we are seeing some normal part and we are seeing some pathology, right? Going a little, this is a sagittal zoomed in image, and what are we seeing? Actually, we are not seeing much of meniscus here. So this is the ghost meniscus sign. Here the normal menisci is seen, and posteriorly there is a vertical defect in this, right? Now this is axial zoomed in image. Here again we are seeing, what is this? This is the anterior root, body, posterior root, right, of medial meniscus. So this defect is seen again. So this is a complete defect in the posterior root of the medial meniscus with meniscal extrusion. So this will be a tear in radial fibers, like we had already discussed yesterday, the radial and the longitudinal fibers. Now these are the scroll through image from lateral to medial, and what are we seeing? We are seeing menisci, right? But is it normal? Is it abnormal? It's abnormal. Why? Because on the scroll through image from lateral to medial, approximately up to 2 to 3 sequences or the images should show you the medial, should show you the menisci, and then it should give you the so-called bow tie appearance, splitting into the anterior and the posterior halves, right? But here it is still contiguous. This is discoid meniscus, and these are various types of discoid meniscus. So it can be complete disc like discoid meniscus, it could be a partial discoid meniscus. This partial discoid meniscus could be this one separated at the posterior root, or it could be a this donut shaped
discoid meniscus. So on sagittal you see absent bow tie sign, and on coronal images what do you see? You see if the height of the meniscus is more than 15 mm, it is a strong indicator of discoid meniscus. Now, very commonly, most of in any given day, spine is such a common scan that we report, right? So, sagittal T2 and T1. So, this was a chronic non-specific low back ache, right? But this was a comparatively young adult. What are we seeing? So, on the superior and the inferior aspect of the vertebral body, T1 as well as T2 hyperintensity. This is a named sign. Yes, Romanus lesion or the sign is shiny corner sign that is associated with ankylosis. So if you happen to see this, you should advise for sacroiliac joint screening. So on screening of sacroiliac, what are we seeing? Loss of joint space with altered adjacent marrow intensity, as well as on stir images we are seeing some component of marrow edema, but mostly near complete loss of joint space, right? And it was confirmed on T1 and T2 coronal images as well. So few words about ankylosing spondylitis has a lot of named signs that you will find anywhere, and that's very frequently asked in viva, even for the long case, or suppose just as a part of table viva. So that should be very well versed by you before the exams. So few words about spondyloarthritis. It is a group of inflammatory arthritis. They have certain common features and they are characterized by inflammation at the enthesis. Enthesis is the insertion site of the tendon and the ligaments. That's most characteristic for this. It can involve axial or appendicular skeleton. HLA-B27 is a common association, although it's not always present. And what is always present is absent of rheumatoid factor. So this line diagram shows inflammation at the insertion site of the tendon, where the inflammatory processes are much more common to happen. This is a simplified line diagram to show the joint cavity, right? So this is the synovium, the cartilage, the bone, right? This is the muscle belly forming a tendon and getting inserted here. So in the pathologies that primarily involve synovium, here you are seeing this orange thickening is synovitis. Where it predominantly starts is at the joint, in the area of joint that is so-called the bare area of joint, where the bone is not covered by the cartilage. So this synovium is in direct contact with the bony surface. Now this enthesitis occurs where just adjacent to it, a little further. So where the tendon or the ligament is getting directly attached to the bone, or so-called at the footprint. So that is seen commonly in spondyloarthritis and psoriatic arthritis. Other sites include along the anterior aspect of spine, giving the shiny corner sign, along the calcaneum, along the tendoachilles and the plantar fascia, in the elbow along the lateral epicondyle. So predominantly axial spondyloarthritis can be radiographically demonstrated, or sometimes they can be occult also. So they are sometimes picked up on MRI, sometimes there is a window period where maybe only the blood parameters or the clinical picture would be suspicious, and a few years later they present themselves on MRI. And predominantly peripheral SPA includes psoriatic, reactive, enteropathic arthritis, and sometimes undifferentiated. So axial spondyloarthropathy is classically characterized by what is called as inflammatory back pain. So like ma'am was saying that you should take the history yourself. Back pain is back pain, yes, but does it increase with the day increasing? Or some inflammatory back pain is classically described as back pain when the patient is sleeping and suddenly, even early in the morning, they get up with intense pain, and sometimes they respond to NSAIDs, and it's not related to the diurnal variation or axial loading or strenuous work. So this is inflammatory back pain that's associated with this. And yeah. So now the diagnosis to call it sacroiliitis, firstly has been revised. Initially it was only bone marrow edema. Now we also study it on post-contrast images. We study for the enthesitis along the superior aspect of this SI joint, capsular thickening, joint effusion, and frank ankylosis. So and sometimes in chronic cases, after ankylosis, you can see subchondral fatty metaplasia also. So that would suppress on inversion recovery sequences. Diagnostic approach, like I was saying, sometimes it can be radiologically occult. So this is while making the diagnosis clinically, the AS Society has a lot of parameters that they consider. So radiographic presence is obviously most significant. After that, presence of HLA-B27, now sacroiliitis on MRI. So X-ray is still more definitive than MRI. And it should always, MRI should always be reported only with presence of X-ray and in the background of clinical history. Now other parameters include the systemic involvement of anterior uveitis, family history, IBD, enthesitis, elevated CRP, etc. So, and presence of any of these or absence of any of these, and there's a comparative analysis, and the rest of the screening is proceeded for axial spondyloarthropathies. Now coming on to the next case. So this is a case in which there was acute exacerbation of chronic ankle pain, and this was a dancer. So some finding is getting repeated here. So this is tendoachilles, and just at the insertion site, what are we seeing? Enthesitis that we just talked about. So there is enthesitis. Is the calcaneum normal? Actually, there is a bump here, right? So there is an abnormal bump in the posterior superior aspect of calcaneum. There is enthesitis in the tendoachilles, as well as there is some bursitis. There is some fluid collection here, right? There is obviously some joint effusion as well, but this is bursitis. So this thing, all the three things together is Had-Lung syndrome. So this is the normal orientation of calcaneus, and how abnormal protuberance makes it more prone for retrocalcaneal bursitis, giving it Had-Lung syndrome. So now this is a 45-year-old male who presented with painful swelling around the elbow joint. So coronal T1, T2 and PD FATSAT image. What are we seeing? We are seeing some T1 peripherally hyperintense, mostly a fluid collection like thing, and also we are seeing some cortical destruction here. On T2, it's heterogeneously hyperdense, right? And on stir image, again, apart from the fluid component, there is a soft tissue component also. This is a case of septic arthritis. Septic arthritis is dangerous because it quickly erodes the cartilage and the joint space, and time is the best thing that you can offer to the patient. The more quickly you raise the alarm and confirm it by aspiration, maybe the joint can be saved. Coming on to the next case, this is a 50-year-old female who was presenting with gradually progressive pain and swelling in the knee joint, right? So sagittal T1 and PD image, what are we seeing? Again, we are seeing some thickening and of the synovium with erosion marginally along the superior aspect of patella. We are seeing some cortical erosion, and we are seeing again some effusion with synovial thickening. This was actually proven to be tuberculosis. So you can raise suspicion. This was a comparatively cold joint, like not as aggressive as the previous joint that we just discussed. And the difference that I want to raise here between tubercular and septic arthritis is, yes, it can overlap the features, but in septic arthritis, there is early destruction of joint. However, in tuberculosis, the joint space is lost comparatively late. So septic arthritis, because the synovium lacks a basement membrane, transient bacteremia has a access to enter the joint space. It can also enter through the adjacent bone or soft tissue infection, and synovial thickening enhancement, osseous destruction form the common findings that we see. In tubercular arthritis on X-ray, periarticular on X-ray, what we see is Phemister's triad, and what it includes is periarticular osteoporosis, peripherally located osseous lesions for the same reason that we just discussed, that synovium erosion starts from the periphery, and gradual or late joint space narrowing. Joint effusion and osteopenia would happen in both because of raised blood flow to the joint, but joint space loss will be late in TB. Now this is another case. So this was a very old patient, 70-year-old, who had an acute exacerbation of very chronic knee pain, right? So what are we seeing on sagittal and axial PD images? So there is a near complete destruction of the quadricep tendon and also the patellar tendon. T2 hyperintense lobulated, some deposition is there along the anterior aspect of the patella, that's also seen on axial, as well as along the posterior aspect of patella also with joint effusion. We can appreciate that comparatively the joint spaces, even though the age is very old, it's not much destructed. Now this is the contralateral knee. He had bilateral disease, and what are we seeing again along the quadriceps tendon here, along the anterior as well as along the posterior aspect, similar intensity deposition is seen, right, and kind of similar kind of erosions are seen. This is not pathognomic, it was aspirated and it was proven to be gout, but it was also super infected. So this was a septic arthritis superimposed on crystal deposition disease, that is gout. So the important thing here is, even if it is a chronic osteoarthritis, sometimes it can get acute exacerbation. It can be acute exacerbation of gouty arthritis also. But these two things don't have to do much. But if there is septic arthritis, that is where clinical proper examination and diagnosis will make a lot of difference for the patient. This is another example of a more classical case at the great toe and at the second toe. And here we are seeing T1, T2 hypointense lesion, that is hyperintense on stir and showing post-contrast enhancement with marginal bony erosions, classical for gout. Now this was a 40-year-old patient, so this is a classical spotter, chronic knee pain. So on sagittal T1 and axial PD image, what are we seeing? And we do have an X-ray for this. So this is, yes, classically synovial, primary synovial chondromatosis. So this is the theory about it, and more likely it is, it can be depending on how those cartilages are getting. If they are ossified, it will be more darker, or if they are still chondroid, and there will be, there can be joint erosion, but not per se destruction, not like destruction of osteoarthritis. Like here, this is a similar case. So along the superior aspect of humeral head, because of the chondromatosis, we are seeing joint, we are seeing this bone erosion that is caused by this loose bodies. Now this is another case, again just to draw comparison. So this was a 45-year-old patient who had mild knee pain, not much symptomatic. So on X-ray and on SAG PD and SAG T1 and PD image, what are we seeing? Even on X-ray we are seeing something very well defined in the Hoffa's fat pad region. On T1 it is iso, and even on PD it is hypo. And there is some joint effusion. It was not symptomatic. It was on biopsy, actually it was proven to be localized form of PVNS. So this case just demonstrates that we have seen more of diffuse PVNS, and we tend to think about it, but it can also be present in a mass-like form and very focally. So that could be misdiagnosed as some neoplastic etiology. So few words about PVNS. And on MR again, they can be heterogeneous, they can be diffuse or plaque-like with synovial thickening, and classically blooming or hypointensities is seen on gradient echo sequences. This is just a comparison case of the previous case. Like we saw a focal disease, this was actually a diffuse form of PVNS, so this was again non-specific history. So on T1 again we are seeing there's some hyperintensity that is due to the bleed. Septations are seen on T2. And then this gradient shows this India ink or the peripheral blooming or hypointensity along it with fluid level within it also. So this was diffuse PVNS. Now this is a asymptomatic patient, comparatively young patient. So axial T2, axial PD, right, and sagittal PD. So the abnormalities, the arrows are at the abnormalities. You can try to decipher it, right? So there is some form of synovial thickening, yes, by the dotted arrow that we see. This solid arrow shows something T2 hyperintense that is getting suppressed on this one PD image, stir image, sorry, and it had some striations within it. Associated with it is a painless knee effusion. This is a benign entity, lipoma arborescens. So this is basically villous synovial mass that increases synovial proliferation and fluid formation, giving rise to asymptomatic knee effusion. So it's a comparatively rare disease. Few more synovial pathologies just to draw comparison with is, so again here we are seeing this is an asymptomatic patient on T1, T2 and stir image. So T1 hypo with some hyperintensity scattered with some very linear hypointensities on T2 and GRE sequences. These were flow voids and this was a synovial hemangioma. This is another case. This is an elbow MRI of a comparatively young male with pain, but there was no acute history or no very, it was not an angry joint, it was not very infectious type of pathology. So what are we seeing? We are seeing some obviously irregular shaped heterogeneous T2 hyperintense mass that was associated with cortical destruction and multi-compartmental extension. This was a synovial sarcoma. So few words about synovial sarcoma is, as the name suggests, but it does not always arise from synovium. It typically is located juxta-articular and can arise from tendons and tendon sheath. It can extend up to the joint, but not always. That's not the defining feature for this. Now this is the last case. So here it was a chronic history of trauma to the ankle, but the pain was persistent and was diagnosed. So this is coronal T1 and PD image. What are we seeing? So this bone is talus, and along the superolateral aspect of talus we are seeing a T1 hypointensity that is hyperintense on stir image with significant surrounding marrow edema, right? So this is osteochondral defect, but it is not displaced like we are seeing. It is reaching up to the superior articular surface in a linear track-like fashion. It's not completely reaching up to this articular surface, so it's still undisplaced. So these are the various types of osteochondral defects that we see. Stage 1 is only where there is a bone marrow edema. Stage 2 can be, there can be cartilage and bony defects. In 2A there is cystic type of defect. In 2B will be a linear track-like defect like we saw in this case. 3 will be a complete osteochondral defect, but it is not displaced, and 4 would be displaced. So thank you.
Thank you, Dr. Bhanupriya. Any questions from audience? No. Thank you. Thank you. Thank you very much.
Thank you, ma'am, for a very insightful and engaging session. Now, may I please request the chairpersons to felicitate the speakers. Dr. Vaishali, ma'am. Dr. Bhanupriya ma'am. Now may I please request Dr. Gaurav sir to felicitate our chairpersons.
जितने डेलीगेट्स हैं प्लीज आ जाइए, एक फोटो लेते हैं। जितने लोग हैं प्लीज, रेजिडेंट्स आप लोग भी आ जाइए, एक बड़ी सी फोटो लेते हैं। भैया दूर से लोग बड़ी सी ऑल ऑफ यू प्लीज, बॉस आइए आइए, सब लोग आ जाइए, जितने लोग आ जाइए। फोटो भी बड़ी होनी चाहिए, फोटो बड़ी होनी चाहिए प्लीज प्लीज। हम नीचे आ जाए, चलो ऑर्गेनाइजर प्लस डेलीगेट प्लस, उनके साथ अलग भी होगा, लेकिन आ जाओ जितने लोग आ सकते हो। 20 सर्टिफिकेट मिलेगा। सब कवर हो पा रहे नहीं हो पा रहे? आ जाओ प्लीज कम। Thank you so much. Thank you. My resident. William, bag लो ली।